Good afternoon and welcome to this session. I am Professor Lakshmi Lingam. I am the Dean, School of Media and Cultural Studies at the Tata Institute of Social Sciences. This online session is about sharing the findings of our study, enhancing the quality of healthcare systems response to sexual assault. We have a distinguished panel. We have the Director of TISS, Professor Shalini Bharat, who will be giving the opening remarks. Professor Shalini Bharat is a well-known gender expert and HIV, AIDS, and TB researcher and expert. She has long years of experience and several publications to her credit. The chairperson for this session is Dr. Shireen Jeejeebhoy, who has long years of research experience in the field of reproductive health, adolescent health and sexual health and rights. And she is the director of the Aksha Center for Equity and Wellbeing. The discussants for this session are Vrinda Grover, a very well-known advocate in the Supreme Court and a women's rights and human rights activist. The other discussant is Dr. Avni, Amin, who is a technical officer at the WHO, Geneva. My co-researchers who are going to join me in making presentations are Dr. Sunita Bandewar, who's a very well-known bioethics and medical ethics, social ethics researcher, teacher and trainer, and Ms. Sita Mamidipudi, who is a research scholar with UCLA, USA. I call upon Professor Shalini Bharat to give her opening remarks.
We welcome all these studies that are critically needed to bring an urgency to the globally shared goal of ending violence against women and girls. And this well-informed, and very distinguished audience of this workshop actually does not need information or any statistics on violence against women. And when we talk about violence, we are talking about all forms of violence: physical, mental, emotional, sexual, and so on. But yet, I believe that some statistics need to be repeated at every such occasion where we meet to discuss the issue of violence against women. And more importantly, we need to be reminded of the interconnections of violence against women with various and numerous aspects of the lives of women and girls who are at the receiving end, including the interconnection with health and mental health aspects. And very importantly, talk about the availability or the lack of it of any formal response apparatus to act against gender-based violence and for mitigating the impact. And this particular study is going beyond looking at what evidence there is about violence and sexual assault against girls and women, but going beyond that, what is the system's response and how does this help women and girls and what can be done about it. As we all know, there is mounting evidence that globally 1 in 3 women is affected by gender-based violence, and almost 30% of these women who have been in a relationship have reported having experienced some form of physical, mental, and or sexual violence by their intimate partners. And in India, the NFHS data has, repeated rounds have shown that almost 30% of women, and in one particular round, I think it was almost 40% women between the ages of 18 and 49 have experienced domestic violence within their marital relationships and within the domestic sphere. And this trend has been the same over the last several decades. This is all fueled by the silence and shame surrounding reporting violence in intimate relationships, especially within the marital homes. Analyses by a few of our TISS colleagues of both large samples, survey data, and community-based studies further support these prevalence data. And I was just looking at some publications brought out by a few colleagues from the School of Health System Studies, and it really is remarkable that we have such convergence of data, which shows that almost 1/3 of the women have had some form of violence or experience some form of violence or abuse in their marital homes or even in their premarital homes. These studies have also highlighted the very important fact that violence against women often occurs within a shared intimate space and within a web of many what we would call as traditional relationships. And hence it is very important to not treat the matter as an interpersonal issue alone. The other insight I think gained is about employing an intersectional perspective to understanding violence against women, since what we see in society is that it is organized around multiple axes of caste, class, sexuality, ethnicity, religion, and so on. And gender cuts across all these locations and identities. And during the COVID pandemic, we found that there has been a spike reported in domestic violence cases globally. And as per some of the statistics which was released by the National Commission of Women, from the time that the lockdown was announced, there has been a sharp increase in complaints related to violence against women and girls after this nationwide lockdown. Now, the Tata Institute of Social Sciences has been working on the themes of violence against women, sexual assault, and gender-based violence and discrimination for the last 4 decades and more, at least 4 decades since I've been here, and I have seen this kind of work happening here. And it is through this engagement that we have mounted several comprehensive multi-agency responses to gender-based violence. One of the earliest responses was, that I can talk about is the special cell for women in police stations that underscored the point that domestic violence is not a personal and family matter alone. It needs intervention from the state and other external agencies. And more recently, our telephone-based service, iCall, further recognized this need, and the Institute joined hands with the United Nations Population Fund and the Marico Health Initiative to provide service to girls and women victims of violence in need of counseling and guidance. This initiative involves free counseling service and capacity enhancement of psychosocial counselors and various gender-based violence functionaries, designing of directory of helplines and creation of knowledge products. We also have the Sakhi One-Stop Center implemented by TIS Hyderabad campus, which is yet another initiative to support women and girls survivors of violence and sexual assault. There's another one which Sukoon works with issues of couple and family conflicts and violence in legal structures. Very important to also say that, during COVID times, several initiatives were offered for especially mitigating the impact of COVID-related, violence. The TIS Special Cell for Women team located in nearly 5 to 6 states, I think they work now in 6 states, responded to over 10,000 vulnerable persons affected by the pandemic, both during and after the lockdown, through telephonic and in-person responses. A dedicated helpline was initiated to reach out to survivors of violence, given survivors dual vulnerability during the pandemic. They were caught at home with their abusers. And in Maharashtra, the helpline Mala Bolaicha Ahe was launched in collaboration with the Women and Child Development Commissionerate. And from the beginning of the pandemic and lockdown, from April 2020 to March 2021, early March 2021, Special Cell for Maharashtra responded to over 15,000 cases of women who reached out for help to support and intervene in violence against them. A social media campaign was also initiated during this time. We are further, strengthening our response by having a special dedicated, response which aims to deliver support and enhance the capacities of counselors working to provide psychosocial support to women and girls in 5 states of Rajasthan, Odisha, Madhya Pradesh, Bihar, and Maharashtra. We are also, preparing directories of GBV helpline services, web pages on resources for strengthening integrated response, and a very important initiative called Swasti, which is a dedicated national multilingual psychosocial helpline providing professional psychosocial and emotional support exclusively to frontline healthcare and mental health workers who are also suffering in various ways, and also providing services to people facing violence of various kinds. So I'll not be, taking more time, just to say that this study itself is very important. And as I said, it does not only look at, what is the evidence, but goes beyond that to say what is to be done and what is the state doing, what is the systemic response. And TIS is, has been working in this space for a very long time. We welcome this particular study and very happy that we are all part of the dissemination workshop. Thank you, Lakshmi, and over to you.
Thank you so much. Dr. Shireen, can you please take it?
Yeah, well, thank you. Thank you, Lakshmi. Thank you, Sunita, Sita, for inviting me to chair this session on this really important, as Shalini has said, such an important issue. It's really a privilege for me. And like all of you in the audience, I really look forward to learning more about the study. So I'm not going to take up too much of your time. Let me just say, as Shalini has, that this is such a significant issue. Violence against women is so widespread in this country. I work a lot on young people, and I know how high, even among young married girls, the levels of violence are. The report, I think, mentions that NCRB has recorded, I think, 4 lakh cases of crimes against women. But this is surely a drop in the ocean of all the crimes against women. And we know that sexual assault is least likely to be reported, given the prevailing norms in this country and the stigma attached to reporting or to the violence. And although it's great that India has a DV Act, POCSO, health system that is supposed to respond to issues of GBV, these are so poorly understood, so underused, and so poorly resourced. And I think the report really does bring this out. This is said again and again, but so apt. GBV is not only a public health issue, but also a human rights issue. And so it needs collaboration across multiple sectors, something we're not seeing. I have skimmed the report, and it's clear that there is not only no collaboration between the health system and law enforcement, but also the response of the healthcare system to sexual assault is plagued by multiple limitations. To name just a few that are mentioned in the report, hardly any facilities have separate rooms for examination. Counseling is not universal. Providers are not aware of their responsibilities in these cases. Hardly any have SOPs. Police requisition forms for medico-legal documentation still require the 2-finger test, and it goes on. I was really shocked reading this report. It's really very sobering, and all the more, given that the sites that have been selected are probably drawn from among the most or more developed districts of the country. So I hate to think what's happening in those districts that are worse off. So that's your next project. The report ends with a number of key recommendations, among them to mainstream ministry guidelines for strengthening health systems, enhancing investments, strengthening health system response, and prioritizing primary prevention. Much more from the authors. So let me stop and congratulate them for the painstaking and careful research. It's really path-breaking on this neglected topic. It's my privilege now to invite the authors to make your presentation. Thank you.
Yeah, thanks so much, Shireen. I'll share my screen. Yeah. Are you able to see this?
Yeah, we can see it.
Oh.
Yes.
Okay, so this is basically the title page, giving credit to the source of funding and title of this project. So the structure of this report, let's say the structure of this presentation of this report is going to be where I shall cover the introduction, the overview and methodology of the study, assessment of the healthcare institutions, preparedness, healthcare providers' knowledge, attitudes and practices in cases of sexual assault and domestic violence at the two sites are going to be covered by Sunita Bandewar and Sita Mamidipudi. I'll come back again towards the end to just discuss the commonalities across both the sites and also allude to the recommendations that we put out in the report. So the study overview and methodology, Professor Bharat and also Dr. Shireen Jeejeebhoy did talk about the kind of figures that we often come up with when we discuss about intimate partner violence, or what we often refer to as spousal violence, physical violence and sexual violence. So violence against women and gender-based violence are widespread issues, and the elimination of the same is a sub-goal in SDG, which is on gender equality. We were looking at NFHS 5 for ever married women facing spousal violence. At an all India level, this is about 29.3. For Maharashtra, it's 25.2, and for Telangana, it's 36.9. Then again, the same age group, or let's say the younger age group, 18 to 29 years, their reporting of experiencing sexual violence before they touch 18 years is 1.5% all India, 6.2 Maharashtra, and 5% for Telangana. And again, these are reported figures, so probably the actual figures are much more than this. The overall in India, as per NCRB, the figures are almost 3.71 lakh cases of crimes against women, which cover a spectrum of crimes, which also includes rape and other kinds of assaults. What we also notice is the conviction rates are very low. They're only 27.8% in 2019. And very often when we talk about conviction rates, many issues come up, and within that, having inadequate medical evidence or having negative forensic reports, and of course, not really believing what the woman is saying, many of these come up in major ways. So the context for this particular study is the fact that in the 2 decades that precede now, we had the Protection of Women from Domestic Violence Act, which came about in 2005 after long drawn struggles of the women's movements. We had the POXO Act that's come out in 2012. And post Nirbhaya, we have the Criminal Law Amendment Law 2013. And close to these changes in laws, there have also been compensation schemes across many states and also central government. And also there's Nirbhaya Fund, which is supposed to be used for supporting victims of sexual violence and also create necessary infrastructure to deal with and mitigate violence against women. One-stop crisis centers have been set up using the Nirbhaya Fund through the Ministry of Women and Child Development. So given the fact that changes in laws have taken place and also different kinds of schemes have been put in place, we were looking at what are the real changes that are happening on the ground. Now, the CLA 2013 particularly has many aspects to it, which cover many things to do with change in the definitions of rape, and also aspects to do with the fact that medical legal care has to be provided. And there are many other clauses and sub-clauses, which also clearly indicate that non-provision of healthcare and also medical legal evidence gathering itself can call for different kinds of penalties to the health sector individuals and of course to the police if they do not file FIRs, etc. And many of these, the clauses within these laws also very clearly talk about the need for survivors' consent to be taken at all points of time. And in the case of POXO, where it is covering children below the age of 18 years, There are also specifications about mandatory reporting by the medical healthcare center to the police, and also all institutions where such episodes occur, they need to mandatorily report. So there are many of these specifications in terms of filing cases, in terms of providing necessary care and protection, and also stabilizing the case stabilizing the survivor who comes to the establishment. All these have been variously articulated, which basically means the larger environment within which sexual violence and domestic violence cases and cases that occur among women, children, and of course a whole lot of other vulnerable groups, including sexual minorities, which are covered by these laws, have to be taken up. And we wanted to see what really is going on. In the year 2014, Government of India has come out with a comprehensive volume that has guidelines and protocols for medical legal care for survivors or victims of sexual violence. And many individuals on this panel and also many participants have extensively contributed towards the development of this particular document. So that basically provides the context for us. And the ministry guidelines clearly indicate that providing necessary medical support to the survivor of sexual violence is one of the most important aspects of caregiving and providing necessary support to the survivor. And that across the board, all establishments have to use uniform methods of examination and evidence collection as per the protocols, and also the necessary specifications that have been given as to what constitutes a safety kit, which is the sexual assault forensic evidence kit. The ministry guidelines also refer to the importance of informed consent for examination, collection of evidence, and disclosure of information to the police, which means at every stage, the consent of the survivor has to be taken. Detailed documentation of history of the assault, collection of relevant forensic evidence is something that's been indicated, and provision of an evidence-based medical opinion. In the sense, the doctors are expected to give a provisional report while they wait for the forensic report to come. Medical support free of cost for survivors of sexual violence, and also first-line psychosocial support and validation following the traumatic experience. In the sense, the woman or child who comes to the health center needs to be believed and also needs to be supported rather than undermined or disbelieved. So maintaining a clear and foolproof chain of custody of medical evidence is something that's been indicated, and necessarily the person has to be provided all the other referral services, like sending the person to the one-stop crisis center or to a shelter home, and providing other kinds of services. So the research that we had worked on, which we submitted to the ICMR and we got support for this research. The objective of this research is to undertake a comprehensive study of healthcare and medical legal care for survivors of gender-based violence, with special focus on domestic and sexual violence, and facilitate identification of gaps in infrastructure and human resources. Now, as part of this study, we have not covered domestic violence or sexual violence survivors because that was not our focus, but we wanted to look at the health system's preparedness and the kinds of practices, infrastructure availability, and the kind of practices that they have in place in order to address and also handle cases that come to their establishments. So we had used the ministry guidelines and the change in legislations as the benchmark, as benchmark documents against which we prepared all our tools. We have covered public healthcare facilities, both rural and urban, largely state-run, as we said, public healthcare. So state-run and municipal corporation. And we covered two districts in two states. We've taken Maharashtra and Telangana. And both, Maharashtra comes in the within the health indicators as a more developed state. And Telangana was a newly formed state and also has indicators on the Human Development Index and GDI, etc., quite on the low level. And within that, we have actually selected districts that have very high levels of NCRB crime rates against women. And our key constituency for the research is healthcare providers, doctors, nurses, ANMs, and ASHAs. We have developed study tools to understand the health infrastructure. So we have created a checklist based on the expectations as per the guidelines and protocols of the ministry. We have created tools for the doctors, nurses, and the outreach workers, again covering all the major aspects to do with the change in legislations and the guidelines and protocols. The study was done between 2017-19 and the report was submitted last year. We had waited for some time to get clearance from ICMR to go ahead with this dissemination. And the study had clearances from the Institute Ethics Review Board and also both the state departments, which itself did take us quite some time. So in terms of the health infrastructure, we looked at, as I told you, we created benchmarks against, we used the benchmark of the protocols guidelines document. We looked at all the physical infrastructure, and I have listed all these items here, medical equipment and supplies, and the medicines and diagnostics that need to be in place in order to provide the support for the women in terms of the necessary caregiving that needs to be given to stabilize the case. And additionally, we looked at the gender sensitivity of the healthcare givers and the kind of attitudes they have and their knowledge of the change in laws and the practices that they actually have in terms of how they go about providing care to survivors of sexual violence. We have used about 21 statements as part of our documents, as part of our tools. We have not listed all of them here. We have the report and we're going to share the report with all of you. Just to put some of the things here, we said like, medical examination of the survivor of sexual violence doesn't require police requisition. It's mandatory for healthcare facility, both private and public, to provide treatment to survivors free of cost. Like that, we listed many statements and we wanted to hear out from the healthcare practitioners what they think about all these questions, because all these questions emerge from the provisions that are there in the guidelines and also in the legislations. So the establishments that we have covered, this is a table that quickly gives you a snapshot, both for Pune and Karimnagar. And you will notice here we largely covered secondary hospitals. We covered the district and sub-district hospitals. We've also covered sub-centers and primary hospitals, though these establishments do not necessarily give direct care, but they are almost the first line establishments that women reach to. So we wanted to know what is the kind of work they do and what is the kind of support they give to women survivors. We wanted to cover much larger tertiary hospitals that actually are the ones that provide support, but it was very difficult, for example, in Maharashtra to get clearance and support and cooperation from the biggest district hospital in Pune, which actually handles majority of the cases. The study participants, you'll notice here, we have urban, rural for both Pune and Karimnagar. And the personnel that we have covered are doctors, nurses, ANM and ASHAs. And we did cover a large number of doctors and a smaller subset of ANMs and nurses across both the sites where we conducted our study. This is again another which gives you information on the type of health facility and the location of the health providers. A lot of these details are there in the report, but just to indicate and point out, so in all we covered about 149 healthcare providers from Pune and about 31 from Karimnagar. Of course, the size of the districts are also different, so these numbers are also different. So now I move the presentation and call Sunita to cover the Pune site and tell us the findings coming from there. Thank you.
Thank you, Lakshmi, and thanks to Shireen and all of the panelists, discussants, and it was very encouraging to sort of get words of appreciation from the from Vrinda and Shireen and Shalini and Avni. I haven't heard as yet, so that's on that note. I would like to quickly kind of run through some of the highlights of what we found in at Pune site. And before even I begin, I think I just wanted to flag one more time that probably I haven't come across these kind of little more district-wide studies of healthcare facilities post Nirbhaya reform, and it was like, if you look at this the duration or the period of the study, it was between 2017 and 19, so much later, like 5, 6, 7 years down the line after the post Nirbhaya reforms came into place, and that's how some of the findings are really concerning, and sort of we need to really work together collectively to kind of change and advocate for these changes. Lakshmi, would you help me moving the slides, please? Yeah, next one, please. So picking up from the way we approached it, so we really used the overall quality of care framework. Many of you, including all those who are on the panelist, and I know many of those in the audience, we've been using quality of care framework, which kind of really stemmed from the family planning and services, etc. That's like 40, 50 decades ago. We used it in both abortion care and also in the violence against women a little earlier within different spaces. So I think it still is a very helpful tool to use and a framework to use. So building on the guidelines and the CLA 13, which provided us the benchmarks. So these were some of the findings. It is, in fact, it's not surprising because it was the facilities that we covered, which were providing care for the survivors, have been largely secondary and tertiary hospitals. We noticed that overall they are reasonably well equipped in relation to infrastructure, equipment, varieties of amenities, and diagnostics, so which includes range of diagnostic. And this covers both general care and specific care to survivors of violence. And of course, one would imagine that there's a variation. So we have in Pune urban-based tertiary hospitals or big hospitals definitely are that they're very, very well equipped in terms of the overall infrastructure. But I think what is concerning here, and we would like to note, is that standard guidelines or the protocols, particularly because they are so well laid out via the ministry guidelines, and CLA provides that kind of a robust framework. So those were mostly missing, or there's sort of kind of an ad hoc approach to how to go about those kind of things. The other important concern was that privacy for patients or the provider interaction, and we are talking about survivors here, was not really the major kind of consideration at any of these facilities, and which reflected not having organized spaces to sort of which would enable privacy for survivors when they get examined, or even the conversation, I mean, leave alone examination. One of the observation, and once again, some of these findings probably will not surprise us looking at what the public healthcare system looks like today. And over the period, it probably is not really improving, but probably it is deteriorating. So there is space. We really came across some of the really spacious kind of settings or the establishment. But what was missing was, some kind of a creative thinking about how that space can be organized. And I'm not sure if there's any literature on, if anybody has researched as how healthcare facilities should be architecturally designed, and it would be of immensely helpful. The second point was also the overall ethos in many of the public healthcare facilities, to which many of us are very familiar with. And so we feel on positive note that things are there, and with some little support, some kind of augmentation, these things can be, the facilities can be really made equipped to be able to kind of really provide quality care to survivors. Lakshmi, next slide, please. Once again, this slide also will not be a surprise. This, all of us, we keep talking, who are engaged in health and health with the health system. With health human resources, there are a number of issues, not very new. Inadequate staff, they've been overworked as a result of that, underpaid, and that really stems from because a good number of, especially the class 4 and class 3 kind of workforce is largely on contract. And I see that as a huge change in sort of, I've been working in with the health system with reference to abortion care, and that was like 25 years ago. And now after those many years, I've been sort of in the field, really kind of viewing the facilities, talking to the health administrators and providers, and the kind of class 4 workers. And there's a huge shift in kind of it really vindicates the concern that we hear in the healthcare movement as of today, that things are the large number of people are on the contract, and related problems, not having relief and breathers, etc. Next, please. Next, please. So what happens when it comes to attending survivors? So we covered largely 2 areas, and I must kind of qualify here. We have huge number of data presented in the report, and soon after we release the report during the meeting, we'll be posting a link, and you'll have access to the entire report in the PDF format in some time. So please bear with us. So we covered 2 areas under this, which was, one was evidence gathering, and the second was what kind of healthcare was being provided to survivors. These are all reported figures and the data from the healthcare providers from across these facilities. So these are some of the findings, that only half of the participating healthcare providers said that they receive, accept, and provide care to survivors, which implies that most of the survivors, if they are approaching public healthcare facilities at different levels, they really don't get attended right at that facility, but they largely get referred to secondary, and largely in our case, we observed that it was all the time to the tertiary hospitals. Most of the time, the examinations of survivors, as and when if they are attending, are conducted by the medical officer who is on duty. Survivors are largely and I think this is also fairly kind of known fact, many of them are really brought by the police because the case gets filed in the police station. At times, they are being brought to the facility by relatives, and it has some different kinds of implication, which I'll kind of flag just in a second. And some of the healthcare facilities only provide immediate care, and they are referred, as I said earlier. Safe kits, I think it was quite interesting. Out of these 45 facilities that we studied, only 6 had safe kits, like the way we define safe kits, and it is to be together. Although at other 14 facilities, the constituents of the safe kits, like whatever is supposed to be part of the safe kits, was available, but it was all spread in different departments, units, which means when the person arrives for the care, somebody has to run around and bring all of those things together, which also means that you don't have the guiding framework, which generally is the case with the safe kits, and which is it's kind of a missed opportunity, we thought, because this is kind of now since 20 years we've been talking about safe kits. We do have the sort of those things available. There's expertise, one can easily get sort of trained to use them, and so these are some of kind of glaring gaps in the quality of care that we receive. Barring some exception, and if I remember it correctly, there are just 2 facilities which are the exception. Most healthcare facilities do not have social worker or counselor, available while dealing with the survivors. And most of these are really it breaches the guidelines, the healthcare facilities which are supposed to comply with the ministry guidelines post Nirbhaya, and it's a big deal of breaching to that extent. Next, please. So this is another important element, and we sort of, we really had very concrete questions about going by, once again, the benchmark. They are expected to seek consent for these three things: medical treatment and examination, evidence collection. So there have to be separate consent sought from the survivors by the healthcare providers if they are seeking the care as survivor, and reporting to the police. So these consent seeking, the ground reality is most providers seek consent for the medical treatment. And this is also need to be looked at from the medical ethics and the Medical Council of India's ethics code, So the consent for treatment is generally sought, but only half of the participating providers sought consent for medical evidence collection. And it is intriguing as why does that happen? And some of the providers and their respective facilities believe that filing FIR is compulsory before survivor is accepted and offered care. Once again, this is a breach of the benchmarks or the guidelines, and sort of, and this relates to the level of awareness that we have observed, and which we'll talk a little bit later. Next slide, please. So this is another disturbing kind of evidence we collected. Many of those in the audience and also on the as participants or the kind of panelists here or the discussants would be familiar with this, probably a ground reality, as kind of despite making concrete efforts and changes in the regulation or the CLA 2013 and the guidelines. On ground, the providers continue to do the two-finger test. Sometimes there is a ground to do that, as here it is said that it is some people treat on case-to-case basis because they would like to kind of make an assessment the extent of internal injury or if there's an infection, and that probably it is justified. But to establish if the sexual violence has happened or not, two-finger test. And that's something, which requires a lot more advocacy with different kinds of constituencies, but definitely with the healthcare providers for sure. Next slide, please, Lakshmi. Thank you.
Sunita, your presentation has about 7 minutes.
Okay, I'll finish in just another minute. I'll run just very quickly. So experiences with judiciary, I would leave this slide for Sita because there are very similar experiences. There are lots of logistical problem with the dealing with the judiciary, and that leads to providers and the facilities being reluctant to take on and sort of care for survivors. I just want to say that on knowledge about Domestic Violence Act CLA 2013 and guidelines, we found that the awareness is really concerningly poor. And I was quite shocked that the DV Act, which came into 2005, almost, like there was a very small percentage who said we are aware of it, but they couldn't really spell out the details. And I don't know whether we should be just not surprised and shocked and not concerned just because there are implementation gap is part of our lives. Yeah, so attitude also had lots of problem. And as Lakshmi had mentioned that we provided those 21 statements, and the idea was to make an assessment whether they kind of, have appropriate attitude, which falls in line with the current progressive legislative framework, definition of rape, TFT, and all of that. Next slide, please, Lakshmi. I think I'm done. Yeah, and I think this is a positive. I think this was so encouraging. Most providers were very keen to get trained themselves in both SV and DV, and they had suggestion about why the Indian Medical Association should be able to do an intervention, and it could also be kind of included in the undergraduate medical program, so that there is adequate sensitization happens right at the outset. So I'll stop here because I think I have finished and will hand it over to Sita, please.
Yeah, sorry, before Sita starts, Lakshmi, can you tell me how long we can continue?
I think Sita will complete in less than 10 minutes. Sita will do
And
it in
then-
7 minutes and I'll do it in 3 minutes. In 10
Okay.
minutes, we'll be done.
Sure.
Yeah.
Okay.
Yeah. Sita.
Thanks.
Hi. Okay, so I did much of the study in Karimnagar, which was quite difficult, mostly because there was really no cooperation from any of the hospitals or the doctors. Nobody was really interested in, thinking about social science research or thinking about responding to sexual violence. So that was one of the biggest concerns that we had. But to begin with, none of the healthcare facilities in Karimnagar were prepared to attend sexual violence cases except for the district hospital. All of the cases of sexual violence were directly referred to the district hospital, and this was not because there were no medical legal registers. 2 of the 3 secondary facilities actually did have medical legal registers, but didn't use them for anything but cases of accidents and injuries. Next slide. In the context of infrastructure, Telangana has had, especially during the time of fieldwork, excellent buildings, very accessible, newly built, with electricity, air conditioning in some of the rooms, some of the hospitals, but none of them had a protocol or a standard operating procedure in place. One of the community healthcare centers had actually fell short of the bed requirement. So even in terms of providing healthcare, they didn't have enough beds. Some of the essential facilities for responding to survivors of sexual assault, especially like Sunita talked about, having safe kits was not something that any of the hospitals had. Some of them didn't even have all of the components of the safe kits. So even if they had to quickly hurry and assemble all of the things they needed, that wasn't something that they could have done because they didn't have all of the things that they needed, especially diagnostic tests for sexual and reproductive tract infections. They didn't have technicians to operate X-ray machines, didn't have counselors. In fact, a lot of the time, they had to use labor rooms to conduct examinations because there was no other space for with that kind of equipment, nor was there any space for privacy, for informed consent. So there were really no architectural arrangements that were made for examining survivors. Next slide. So the heads of hospitals mostly reported a few HR issues that they felt were, some of their biggest obstacles. One was that they said they had only one female gynecologist or no female gynecologists. And even if they did have female gynecologists, they weren't available on staff. The Sexual Violence Act, the CLA doesn't really say that female gynecologists have to be the only people examining survivors or providing medical care for survivors, but none of the hospitals had either gynecologists or any other primary healthcare providers provide care. They also said that there were no police outposts at their facilities, and this was something that they considered, a really big obstacle to providing care. None of the doctors, nurses, or outreach workers received any training, but a lot of the nurses and the auxiliary nurse midwives, ANMs that we interviewed, they're poised at a very important position where they may be the first point of contact for survivors at the village level, but they really don't have any training to adequately respond to sexual violence at any level. Also, counselors are not available at any healthcare facilities, nor are social workers available at any healthcare facilities. In terms of knowledge gaps, there was no idea that a new law was passed, nor was there any awareness about the Domestic Violence Act that was passed in 2005. Many medical practitioners at the primary level felt that medical care was not adequate, that they had to be, also evidence collection procedures that had to happen simultaneously. Sexual violence was criminal justice and automatically demanded much more than medical care, which was something that we had a problem sort of understanding or explaining. Also, a lot of the doctors talked about intervening in the survivors' decision-making processes to report violence, frequently counseling them against seeking legal recourse because of the shame associated with doing that. There were no procedures, written forms, or oral standards for seeking consent, either for receiving healthcare or for evidence collection. There was a prevalent belief that the presence of injuries is necessary to arrive at the opinion that women have been raped. There was also the assumption that filing an FIR is compulsory and necessary before providing care. Next slide, please. Some of the gaps in evidence collection was that the changes in the law have not been reflected across the board in any part of the district. The forms that were required are still maintained by the police, even though the letterhead that the doctor uses and signs has the hospital's name on it and the doctor's name on it. These letterheads are actually maintained by the police and provided to the doctors whenever the police feels that an examination is necessary. Again, they don't have safe kits as prescribed by the guidelines. They also don't have spare clothing available for the survivor to change into. There's a whole list of items in the report, things like combs, nail cutters, wooden sticks, and envelopes or boxes for storing evidence samples. None of these were available in any of the healthcare facilities. Like I said, Professor Lingam spoke about earlier, some of these requisition forms still use two-finger and hymen tests. Survivors were across the board referred to as victim or case and never as patient or survivor. And especially in POXO cases, and this was something that again was quite disturbing, a lot of the adolescent girls who were examined, who came to hospitals, were referred to as love affair cases, and they weren't treated as genuine cases because it was just assumed that they had eloped with their boyfriend and that their families were interested in making a case against the boyfriend. And finally, with regard to providing testimony in court, a lot of the doctors that who had conducted examinations talked about how they have a really high outpatient backlog. Some of them see between 80 and 120 patients a day. And so taking a day off means that their backlog really builds up over the week. The other problem that a lot of people faced was that there was usually a very large gap between the examination and their date of testimony. Usually these gaps lasted anything between 2 and 5 years. They had to request a fellow medical officer to take over their shift at a hospital, which usually was very difficult to find. It was difficult for them to get permission from their supervisors to go attend court. A lot of the doctors talked about how it was difficult for them to navigate the complex court system, especially the way that it's spatially organized, the process of cross-examination, repeated adjournments, long waiting periods. So all of these were, issues that they talked about, providing testimony. To sort of conclude what I had to say about Karimnagar, none of the facilities sampled in the district are prepared to respond in a sensitive, timely, systematic manner to survivors of sexual violence in accordance to the guidelines. And very few of them actually are able to provide care and conduct examinations, in spite of being mandated to do so by the guidelines.
In terms of the commonalities across the two states, what we find is the physical infrastructure is good. However, preparedness to handle SV cases is poor due to lack of protocols, standard operating procedures, consent forms, safe kits, medical supplies, which basically compromise the, the issue of privacy and also the dignity of the survivor. The critical competency across many of these establishments, the doctors have very good competency. They can really measure up and do this kind of work. Police lead all the procedures and they continue to have protocols and forms which are not as per the change in laws and also the ministry guidelines. In fact, we found that Karimnagar also has a form which asks for a 3-finger test and also asks whether the doctor can write whether rape has actually occurred. So these are really quite discomforting aspects. Then we do see in both the states, doctors have a lot of difficulties with giving evidence in the courts. Doctors are frequently transferred, but they have to go back to deal with an old case. And courts also ask the doctors to depose in terms of yes and no, and very often the cases are not all that simple, so they also find themselves quite baffled. Referrals to tertiary hospitals is the order of the day. So therefore, the hospital settings at the, what we call as a PHC level, CHC level, etc., never take up any cases. Training is something almost all of the health personnel whom we interviewed, they were quite interested and also prepared. However, they're concerned about the increasing workload whenever they take up any kind of training. So in terms of our recommendations, Shireen did mention some of these. Just to reiterate, we think that the ministry's guidelines need to be mainstreamed and they need to be accepted across the country in all the states. I think about, as per one of the Sehed reports, there are about 6 or 8 states to date that have accepted the guidelines. Therefore, there's a lot of unevenness in how these guidelines are misrecognized or misused or not at all used. There is a need to enhance budgetary allocation because anything to do with GBV, most of the hospitals will say that they don't have funds to handle the load that they get to their hospitals. Then violence against women related indicators need to be part of the health parameters that Niti Aayog actually put in place, and it assesses every state every year and comes out with the health report. Unless these are there, in fact, it won't even be something that we contribute to in terms of achieving SDG 5. We need to enhance SV response at all the levels of healthcare facilities, primary, secondary, and not just tertiary, but also primary and secondary. Strengthen intersectoral coordination, health, police, and legal departments, and recognize domestic violence as a public health issue. We have not made a lot of observations in our presentation, but the report really tells you how domestic violence cases are often not recognized by the health setting, and routine healthcare is provided. Fund and support technology enabled training, because most of the time they'd say they can't get trained, they don't have time. But I think the way we are doing everything online, there can be a lot of possibilities where healthcare providers can go through their training using their phones and also through digital learning, content. Prioritize primary prevention of GBV in collaboration with civil society groups to address SDG 3, 5, and 10. Thanks. And I think we've taken more time. We'll just stop here. Thank you. Yeah, over to you.
Thank you so much.
Yeah, thanks.
Oh, it's really an excellent presentation and excellent report. Really advise everyone to read it very carefully. Okay, so moving from the presentation, may I ask Vrinda now to make her discussant comments? Go ahead, Vrinda.
Thank you, Dr. Shireen. And first of all, I want to add my congratulations to Dr. Lakshmi, Dr. Sunita, and Sita for a very important report. And why I find it of great relevance for us, as was mentioned during the presentation also. These changes came about both in the law as well as the medical protocol, etc. in 2013. We are now in 2022. We're almost a decade later, or a little less than a decade. And there has been so much public discourse from not just civil society, but actually from the state around this issue and these changes. So what really is the impact on the ground? Today we have, from your study, evidence to show where the gaps in policy are, where the gaps in knowledge are, which are actually alarming and disturbing. And what is it that the state needs to do? Because we know that the state continues to instrumentalize the issue of violence against women, particularly rape. And while it has today become part of the cacophony that the state is creating, the effect that it's supposed to have in terms of policy, health infrastructure, the legal system, none of that is percolating down, because policies are based, and the only change we seem to see in law since then is how do you enhance sentences, which is actually like a very, very nasty joke, because what you have is very low convictions. So when nobody is getting sentenced, and never has the feminist movement in this country asked for higher sentencing at all. That has not been the purpose or our understanding of justice. So I think this report provides us with actually the nuts and bolts of what the state should do, where they need to put, where the money needs to be put where their mouth is. We also know that even governments which pretend that they have a very real concern, and I think this is across party lines, regardless of which party it is, they will either invest in technology like CCTV, whereas your entire database and studies showing intimate partner sexual violence. What this CCTV in the bus is doing is mind-boggling, but the state budgetary fund goes there. And also at a time when we are seeing in India, the woman voter actually now coming out in large numbers and voting. How do we make issues of actually getting services at the district level, services in the public health facility of what is promised? Because the issue of safety of women, and we would of course as feminists articulate it differently, but the issue of safety of women does today feature in whichever variant in election manifestos. How does that translate? What do we assess state's commitment to us? This report, to my mind, provides us with material with which we hold the states to account. So thank you very much for this study. Moving very quickly from there. So one of the important things that the Criminal Law Amendment Act 2013 does is to expand the definition of rape. Now, when you expand the definition of rape, actually the corollary ought to have been that the significance and relevance of medical evidence is supposed to actually come down, because can there be a lot of medical evidence, for instance, or forensic evidence of digital rape, of forced oral sex. Instead of that, your study shows, and my own experience in court shows, that this obsession with seeking corroboration from medical evidence has not diminished, and we clearly need to do much work on even on taking this forward. Again, my experience in court actually shows that medical evidence is rarely, and it's not it's not just WHO statistics, which Avni can tell us much more about. In real cases, most of my cases do not have medical evidence, or they will have, for instance, in one case, there was no ejaculation, but there was forced penile thrusting. After a few days, she had an infection. Now, the day and she had reported immediately the next morning of the forced sexual assault. The evidence, the medical evidence did not yield anything. Then she went to a private doctor later, and that doctor was actually attentive enough to say this kind of infection happens only when there is some forceful pressure put on the vagina and those areas. Now that those dots have to be joined. Those dots there is because you're going to take the person, she's reported, you've taken her, your story's over. She has some bruise marks on other parts of the body, which of course nobody has bothered to see at all, because if you've come with a rape complaint, it's only the vaginal area, that area which is going to be examined. So there you have people, that kind of understanding medically has not developed. And when you bring a private doctor into the witness box, you are looked at with complete suspicion by the court. That, oh my God, if it's a private doctor, you obviously put him up to coming and saying these things. Not understanding that this evidence can come later. So that kind of knowledge building also and capacity building we need. On the other hand, one has a case where it's a case of digital rape and forced oral sex by the man, and she complains after a few months. But even when she complains after a few months, there is an insistence by the police. We will take you to for medical examination. And she point blank says, no, I'm not going to have an examination done when I was raped 3 months ago. This is ridiculous. But it's like you have to tick that box now because the law says so. Coming back to the issue of what the courts have been saying repeatedly on two-finger test. At that time, I had gone in Delhi to some of the, at the time of the formulation of the protocol, to understand what they do. And I think it's interesting, and your report actually captures this part of it in your interface and interviews with the doctors. And the doctor kept insisting that, I have to do at least use the speculum. I mean, I can understand use of speculum for injuries, it should be used. But she said, but how will we know that she's telling the truth? So I kept asking her, why do you need to know? Like, who are you in this whole process? You are simply a doctor. Give her the treatment she needs and put the report together. But there is this whole thing, but no, how do I know this woman is not lying? So I think what that constant prejudice that we deal with, and I think here what's very fascinating in what your report captures in some of the interviews, when they are not disclosing that she has been raped, it appears that they are doing that because they are protecting her from dishonor and public shame. When they are disclosing, despite her non-consent, it's because they see themselves as some crusaders of justice for women. So I do not hear in the interview of the doctors or the health workers any respect for the autonomy or the privacy of the woman in either case. So whether they speak, even when the consent is being respected, the reasons why it is being respected are extremely problematic. And I think the issue of respecting the woman's autonomy and consent is actually missing from their own understanding. Thanks, Shireen. I'll just quickly move forward from there. We spoke about the health ministry protocol, and I think it's important to underline here that the Verma committee actually set out recommendations for many ministries, including, say, the Ministry of Surface Transport. because this did take place due to absence of good public transport. The Ministry of Health, under its then Secretary Keshav Desi Raju, who's no more with us, actually was the only ministry which took the lead, invited Sehat, myself, many others who have been engaged in these issues, and doctors and gynaes working within the government to prepare these protocols. The protocols can be taken forward by state governments. The union government doesn't need to do this. Health is a list to entry 6 subject. So the lobbying can actually take place and advocacy can take place with state governments, particularly when governments are all almost, dying to protect women. So maybe they can actually start doing some of that work by putting systems in place. I do read and hear very clearly, this is my last comment for now, the difficulties in the courts when doctors, etc., go to evidence. And I actually totally endorse the discomfort, the disrespect with which they feel they are being treated and handled in the court. And here I think we need to get all these actors in the same room, so that there is no, even when at least I have been part of workshops, we have never got the police and the judges and prosecutors with doctors. We have done these workshops, these trainings separately. I think we need to create spaces for them to talk and hear each other as to what is, and each one is performing a role. So nobody has to think that my role is greater. And I will stop here for now. I have actually assisted the Hathras family in the appellate court. And if an opportunity comes during this, I'd like to just share a little bit of a timeline, because I think that case is so, just lays out so clearly what is wrong with addressing the issue when a woman needs medical and investigators to step in. Thank you.
Thank you, Vrinda. Very interesting, more depressing news. And now turning to Avni, for what I hope are good news, because Avni is going to talk about the future and ways of taking forward the ministry guidelines. Go ahead, Avni.
Thank you, and thanks everyone, and Lakshmi especially, and congratulations to the whole team. I'm going to focus my remarks on 4 areas. The first is really just, what sort of stood out for me in terms of this particular study, contextualizing it in terms of what we know about similar efforts done in other countries. And particularly, I'm happy to sort of speak to work that we've been doing in Pakistan and Afghanistan and Cox's Bazar in Bangladesh. So sort of similar settings. And then maybe just point to some research gaps and needs and how to strengthen the way, the way forward and what can be done. I think just to start by commending the team on a well-designed study around multiple methods and triangulating the findings with so many different sources and contextualizing it in context of the law, the policies. And more importantly, and I was struck by the fact that you, for each section, really compared it to the standards, the established standards, and that really provides an important reference point to say, here are the standards established, and here are the gaps in relation to the standards that the government has established. So I just wanted to commend that. And I think just, this is a very important piece of work that will contribute to the body of evidence that we have on this topic, in particularly the low and middle income country settings, because there is a general lacuna of this kind of work in these settings. What I'm going to do is just in terms of the findings, position it in relation to what we have in the WHO guidelines as the 5 minimum standards for health systems response. And where, I see the similarities and where I see some glimmers of hope. In particular, I think we have 5 standards, minimum standards that WHO has established for health systems response to violence. The one is the availability of protocols. And clearly your study shows that that is a lacuna, and it continues to be a gap in terms of the availability of protocols. Not that they don't exist, but they're just not available to the healthcare providers when and how they need it. The second is the infrastructure. And again, I'm struck by the fact that this has been a problem. We have a clear recommendation that in the infrastructure, you need to have privacy and confidentiality measures in place. And clearly your study shows that despite the physical infrastructure, the lack of a private space is a problem. And I think it was Sunita or Sita, I can't remember, who said, are there models of creating private spaces in facilities? And yes, there are. The Strengthening Health Systems Response to Violence Against Women, which is a health manager's manual, has in the infrastructure section, different ways in low resource settings you can strengthen the privacy and confidentiality measures. And we have some very good examples in other low resource settings. In Afghanistan, provision of curtains. In Kazakhstan, for example, they just put a fan outside the curtains so that the noise of what was being discussed inside would drown out and others couldn't see it. So, simple solutions that didn't require construction of big buildings and rooms. Strengthening doors in some places, for example, they used a closet where they were keeping cleaning supplies and made it into a nice consulting room. So, some of these things don't require a lot of resources as people imagine. I think the third one, which is very striking again and nothing new, is really the health workforce competencies and training. The lack of training is quite evident and abundantly established in your study on many, many fronts. Basic knowledge of the laws to the practices that we know have been problematic for a long time, to sort of the personal beliefs and biases of providers that are hampering quality care, and the inability of providers to actually provide counseling. And I get the fact, and this is universally the case, that providers say we don't have time, we're overworked, it's beyond our capacity, we need specialized people, we need funds, this is universally the response we get, no matter which setting we've done this work in. And what we've demonstrated in our study with Sehat in Aurangabad and Meerut Sangli is that even in very busy hospitals, there is possibilities to do some very basic stuff feasibly, and it is acceptable for healthcare providers with limited resources, limited time. And it's really a question of training them to do things in a different way and incorporate it in their routine care. And then really thinking about who needs more attention, more care, and then having a system of rotation, a system of a roster where, you say nurses and social workers, where they're available, are able to provide that more intensive care. So even in a public hospital, it is possible to do it. And that's, I think, the good news of the counterpoint to what your study is showing. And it's possible to train providers within 2 days or 3 days period with the use of mixed approaches. The third area, which is striking in your study, and again, there is good news on that front too, is that specifically poor referrals, which has been a plague of all health systems' responses to violence. Again, it's possible to do it with referral directories, establishing linkages. In the Aurangabad and Meerut study, the healthcare providers started keeping the protection officers' phone or WhatsApp numbers and just really establishing those linkages with them. So I think, again, referral issues can be resolved. And then the fifth piece that I was struck by is the lack of job aids and IEC materials, which is, again, one of the minimum requirements and standards, but again, not insurmountable. The job aids are there, the Ministry of Health guidelines are there. And again, in very busy hospitals, we showed that we could actually print and make these available for the public, as well as for the healthcare providers in different languages, so that they have something to remind them of what the protocol requires of them. So how do these findings relate to what we found in neighboring countries? What we found, for example, in a exactly similar assessment conducted in Khyber Pakhtunkhwa in Pakistan, it really depends on the level of the facilities. And I think I would maybe encourage you to see if there are differences in your findings by the level of facilities. I sense that there was, but it didn't come through very strongly. In Pakistan, for example, only 15% of primary healthcare facilities had the ability to provide care, but 60% of the tertiary facilities did have some minimum infrastructure and requirements to provide care. The other issue, of course, has been the lack of clinical skills and competencies and the beliefs. And again, training has been one of the ways, but I would really emphasize to not focus on one-off training, but really think about, how do we make institutionalized training as part of the pre-service, as part of the in-service training for healthcare providers as a way forward. The other issue that I was a little perplexed by was the whole issue of some of the providers saying that the FIR was required before treatment. And I didn't quite understand that as a requirement of the guidelines or the law. So it was some of the things that perplexed me as to whether this was a lack of clarity or ambiguity in the interpretation or just lack of training. And this is not unique to India. In Kenya, for example, police reports are required before treatment. And we've worked with the ministries, the civil society groups have advocated very strongly to do away with this requirement because it really hampers timely treatment for some of the symptoms. And it really deters women who don't want to report this to the police. And we have to, as Vrinda said, respect their autonomy and choices in saying that if you don't want to report to the police, but you do want treatment and care, then you have the right to deliver that care. And then the other piece that I was struck by, again, nothing new. We have done a study on how many countries have clinical protocols, and only 48% of countries worldwide have clinical protocols for post-rape care. In India, one of the things that I was struck by in your study is that domestic violence does not have any clinical guidelines or protocols available. And that's a big gap. It's a huge gap in the way forward, because for sexual assault, there is at least a standard in place. For domestic violence, there is no standard in place to actually build off and start training healthcare providers. And it is one of the important ways forward. The last bit that I wanted to point in relation to the settings gap was basically the gap between what is there as the need for psychological support and counseling and what is actually available. And in fact, WHO guidelines, and I think the ministry guidelines make it similar, that every woman who walks into that clinic, at minimum, if nothing else, even if she comes 8 months later, has to receive psychological support, regardless of symptoms, regardless of injuries, regardless of anything, has to receive psychological support. And so when we see this only as a medico-legal issue, but not as a healthcare issue, we really miss out on the opportunity to provide psychological support to a majority of the survivors who do not come in the first 96 or 120-hour window period of when there is some medico-legal evidence collection possible. Gaps in research, I suspect if you do this in, as Shireen was saying, in other states of India, you will find similar findings, but maybe worse or less worse depending on the context and the health infrastructure. Perhaps if you go to Tamil Nadu, it might be different. And if you go to UP, Bihar, I'm sure on every indicator and standard, it might be slightly different. But I do believe that doing the study is an important baseline. And what I would encourage TIS to think about is to use these findings as a baseline for where these facilities are in terms of meeting the minimum standards, the additional sort of the higher standards, and what we call the ambitious standards for clinical care. So some facilities are probably at the very basic level of not even meeting the 5 minimum standards. Others may have the 5 but not meet the 10. And then the tertiary facilities may meet 15 out of the 20. And you kind of get a sense of how far each level of the facility has to go. And there are tools like the quality assurance tool that we have that can help you analyze this data in that sense and set benchmarks to say, okay, primary health facilities need to meet these 5 standards. The tertiary facilities need to meet these additional 5 standards. So I think that would be an important way to proceed in terms of setting benchmarks for both Pune and the other district, and something that can be done, encouraged in other districts and states, not as a research project really, but to really help people think about quality and to think about quality of care. The other last bit I would say, and I just have 3 takeaway messages. One is it is possible to do this even in the low resource settings. And I will refer you to the study that Sehat and WHO did with Aurangabad, Meerut, Sangli, and I'm happy to post the links in the chat box later. We can do it. It is possible to do it in a very creative way, but there are 3 things that you have to think about in training health workers. You have to create champions at the senior management level of the administrative cadre who will take lead, who will inspire, motivate, and who will be the supervisors and mentors. Don't think about it training individual cadres of health workers, but as multi-cadre teams, because that really lessens the burden on each individual healthcare provider and generates a bigger buy-in in terms of saying this is not just one person's job, but every person's job. The third thing is to have trainings that really focus on challenging and questioning the value systems and the beliefs. And there is a lot of very creative methods that Sehat can I'm sure, share in the training materials on how you can do that. And the other piece is exploring innovations. I know you mentioned the importance of reducing the training burden. We do have online Zoom training methodologies to deliver during COVID. So I can share it, and the curriculum for online training will come out soon. And very soon we will also have an e-learning for healthcare providers to do it, to do a self-study. But I'll also post the link of an e-learning that is already available on clinical management of rape, so that people can kind of do the self-study. But I will say, don't do away entirely with face-to-face training. Skills are extremely hard to build on an online modality. You do need to be able to practice those skills. So a hybrid approach to training is really what I would recommend. And then the last bit I wanted to mention about the way forward is the whole issue of safe kits. And I know you talked a lot about the lack of availability of safe kits, but we don't necessarily need safe kits. What we need is the elements inside the safe kits all assembled in one place. Safe kits, if they're not used, if the elements are not used, can lead to wastage and lead to really expensive wastage in the health system. So the important message is not the availability of safe kits, but the components of safe kits, to make sure that they are all assembled in one place so that health providers can use them in an economically viable way. And that has been the WHO position even in other resource settings. I'll stop here.
That was really very encouraging, and looking at the way ahead. We have lots to do, but at least there's a way. My very pleasant duty now is to say we're all going to release the report now. Some of us who have hard copies will show the hard copies, and the link to the soft copy will be shown. So please show. Oh. So we have about 10 minutes for questions. If you see the chat box though, there are some very interesting comments made. We know now that what this report is showing is really resonating even in Pakistan, where we have a participant who's contributing a lot on the chat.
Can I just quickly add something here?
Sure,
one of the important findings that you come to is the dismal level of awareness, whether of the Domestic Violence Law or the amendments to the Criminal Law Amendment Act, which obviously has then a slew of consequences, including this insistence on FIR, etc., etc. you have a legal services authority in every district and in every state. It is headed by a district and sessions judge. There are three primary tasks that all legal service authority are meant to discharge in this country: provide legal aid, legal awareness, and lok adalat. Of course, over the years, things have got skewed. There's a larger budgetary allocation towards lok adalat because we have a legal system that is falling apart due to it being overburdened. But legal awareness is something that they have to conduct. Now, can health workers, doctors, can there be a conversation with the legal service authority that have regular legal awareness for this constituency, as they play a critical role within the legal system now? So perhaps that's one channel of communication we need to open.
Thank you. Other comments, questions?
Yeah, I just wanted to add a couple of observations which we have not really put in the PowerPoint presentation, but it's there in the report. What we found was, in the case of children who come to hospitals because of sexual assault, there is much greater acceptance that something has happened, and the narrative is also accepted, and the entire health system, including the community, comes together to really do something about it. When it comes to adolescent girls and girls, let's say below the age of 18, there's always a needle of suspicion. We know that in some cases, these are consensual relationships, and probably the girl is pregnant, or because she's eloped and she's come back, the family brings her to the hospital to check what is her status in terms of her virginity. Then the hospital at times, says that we won't do anything till you report to the police. Or sometimes they say don't report to the police, and they join in thinking about it as a family honor which they have to protect, but definitely look at it as a false case. Okay. And in cases where women come themselves and they say that, they have faced sexual assault and would like to be checked, and they would like to do something, this is when there's a lot of needle of suspicion on the woman, because she doesn't fit the understanding of being a very credible victim, So a woman coming on her own, or a woman coming along with her parents, but quite clear about what she's going to agree and what she's not going to agree. This person who seems to be quite clear in her head and knowledgeable and quote unquote empowered and seeking autonomy and privacy, they are definitely seen with a lot of suspicion. Okay, so what we see is the responses of the providers, which could be doctors, nurses, all these vary depending on what they think about a person as a credible victim, whether it's a child, adolescent, or a older woman. In the case of, married women who come with physical and spousal violence, or even come with sexual violence, very often there is very symptomatic kind of treatment that is done, or at the most they just refer the woman. And very often these women have different kinds of trauma, and also a lot of reproductive tract infections. Sometimes they also contract TB and many other things. So doctors often just give them some medication and send them away. And when we spoke to them, did they come across cases where they suspect it could be domestic violence? They do say yes. Because if a woman comes to the hospital repeatedly with a variety of problems, they know it could be because of domestic violence, but they don't do anything about it. They don't recognize it as a public health issue, and that they have to do something about it. And when we spoke to the ASHA workers and the ANMs, ASHA workers are in the community and they are also aware, but they actually say that they are told by the hospital that don't do anything that's beyond your brief. And they don't see this as part of their brief, okay? And at times they again say that maybe this woman also has done something. That's why she got beaten up, Or maybe she has an extramarital relationships, and because her husband comes to know and now she says it's rape. So there's a lot of this kind of very questions of morality, moral policing, moralistic kind of, judgments about women. And therefore you really wonder, when do they look at themselves as people who have been scientifically trained, to recognize that women have rights and children have rights, and they have to give this in a very dispassionate way and neutral way to make sure that they recognize the rights of these people. They don't. They actually carry the cloak of their caste, they carry the cloaks of their class, and they often refer to words, they say these statements like, ye log hamesha aise hi hai, especially PHC doctors always had these statements, nurses also. Ye log hamesha aise hi hai, means they come to the hospital with a problem, but when we try to solve, they say the community retracts, they all have a fight among themselves and they go away. So we don't do anything about it. We see a lot of these kind of issues, within the at various levels in the society about how they respect and recognize women's rights, women's dignity, and issues of privacy. It's very, very disheartening, and you really wonder, where will we go with this kind of scenario?
No, I was just reflecting on what Lakshmi was saying. And obviously part of the problem with the health provider's own belief system is that they're coming from the same societal backgrounds as obviously all of us know. So one of the things that I know this is something Sehat has done quite extensively in the medical schools in Maharashtra, is really working at the pre-service, the undergraduate curriculum level.
Yeah.
To embed the concepts of respectful care and, kind of really thinking through these power issues, the bias issues, be it based on caste or class or gender, and to really embed that in the way curriculum is taught. Not just, not just in relation to violence, but I think it could really have a very powerful impact for any kind of clinical care, be it on abortion, be it for adolescents, etc. So it does speak to the need to really embed this work at the pre-service and undergraduate level.
So I just want to really quickly, half a minute possibly, or 1 minute, in kind of, going back to Avni's point about really, looking at the undergraduate medical education, and just to flag, there are a number of groups and sort of, entities who are really concerned about what is happening within the medical education establishment across the country. And one of the things that we have been working, and there are a lot of other people, that, there is casteism which is so entrenched within the medical education. And that's something I think we've been talking about for the last 30 years, but that I think we've been sort of moved from discourse to really talking about what could be the intervention. So the new education policy that has been just brought in, that huge amount of critique because there are lots of problems, but it does really make reference to introducing humanities, and it just kind of, there's a window of opportunity to bring in those kind of, aspects and integrate those into medical curricula towards sensitizing and making students aware of what are our circumstances, what are our social organization, what is the system in which we live and are grown up and, molded, which really shapes our worldviews and whole lot of things. So I think there are kind of, those kind of avenues now opening up where a lot of these things together, as you Avni rightly pointed out, it's not just the gender-based violence, but, the discrimination within the institution that's happening, and whole range of things, So maybe, another 10 years, and we only can talk in terms of decades that takes for any changes, little changes that we can bring about. So I just wanted to flag that point here. Yeah, back to Shireen, please.
Okay, thank you. So there's a question. Is there any awareness or discourse about marital rape in health professionals? Would you like to make a comment?
Yeah, so basically, I think across both the sides, none of the doctors really have used this term saying that they recognize marital rape. They do say that, they do see cases of women who come with sexual violence. They recognize it if the woman has been separated from her husband and she faces sexual violence by him, though they are separated. So that is when they feel compelled to record it and also let the woman know that she can do something about it. Otherwise, if she's within the marriage and she's not actually lodged any kind of complaint against her husband, they don't really see what they can do about it. So though the DV Act says they need to prepare a report, they need to also make that report available to the social protection officer, the DV protection officer, and also give a copy to the woman. These modalities they don't really they're not aware of, nor they do anything about it.
Now we have two last questions.
Yeah, I'll quickly answer. In fact, it's one is about abortion for children underage in the POCSO cases, and the other has to do with trans people and sexual violence on them. In fact, I think we've not really asked in such a pointed manner about if trans people's cases come up, how do you handle? Because we looked at sexual assault victims in a very general sense and tried to see what kind of attitudes and practices the doctors have. And we've not really specifically asked about would they withdraw MTP services for POCSO cases. We've not, so we won't be able to answer that. Yeah. Thank you.
Okay. Thank you. We're really very good, almost exactly on time.
Yeah.
So now may I turn it over to Lakshmi? My job is done.
Thank you.
Thank you all for being so patient and so great.
Yeah. Thanks so much, Shireen, for navigating this so well. I think each of us couldn't really, at least as presenters, we really were holding ourselves back to see that we don't go on and on. It was so wonderful to hear Professor Bharat, Vrinda and Avni, and so many hopeful things that we heard from Avni, and we always are very inspired by the work of Sehed, and we look forward to this merging with the work that they are doing so that we have a lot of force to work together. So I would like to close this particular session, this meeting, online dissemination meeting, by thanking Professor Bharat for all the time she's given. Thanks to all the panelists, Vrinda and Avni, for giving your time. Thanks to all the participants for being here. And of course, a big thanks to ICMR for funding us. And a very big thanks to our computer center, Shiv Kumar, for being there to see that we've not faced any technical glitch in this session. And thanks, and have a very nice evening. Thank you very much.
Thank you.